Hi, so I'm going to talk to you about some of the things we were trying to illustrate with those cases and actually how things have changed around the diagnosis of urinary tract infection and also some of the treatments changes that we've had to make. Because you've already alluded to, we're seeing an increase in resistance and problems with not being able to rely on the usual treatment that we've relied upon in the past. And what I really want to sort of try and highlight is actually the importance of actually getting the right sample and right interpretation of the sample to actually make sure we actually then implement the right care for the patient. And one area that we certainly have found is around diagnosis of UTI. There's been over sending of samples, over dipping of urines, and then diagnosis of urinary tract infection, and then overuse of antibiotics, and then the selective pressure for resistance. So if we're going to actually tackle the rise in resistance that we saw in that data, we actually need to use antibiotics appropriately. And part of that is actually sending the samples at the right time to actually inform the use of antibiotics. So why urinary tract infections? Well, it's the commonest cause for sepsis, so we do need to make sure we get it right. So patients coming into hospital with sepsis, the commonest organism that we see is E. coli coming from urinary tract infection. So we do need to be getting it right in those who actually do need antibiotics. By the end of this, we hope you understand the use of dipsticks, and obviously some people are aware of the sort of updated guidance, but we know across the healthcare system that message hasn't got out there to everybody. And if we're not all doing the same thing, it's very easy then to slip back into the practice that we had before, or somebody saying, don't do a dipstick here, and then meanwhile somebody else is doing a dipstick. That's just going to cause confusion. So, why I already alluded to urinary tract infections. It's the commonest cause for sepsis. It's also the second common indicator for actually antibiotic treatment as well. And in the laboratory, we get flooded with urines. They're our commonest samples that we get into the laboratory. So we get nearly 1 million samples a year. On a daily basis, we get 600, 700 urines coming into our laboratory. It's interesting, if you talk to the companies that supply some of the machinery we use in the laboratory, they say that's a very UK specific thing that we're getting so many urine samples. They supply other European countries and they don't see the number of samples that we're seeing. So it's actually trying to make sure we rationally actually send these samples. And so we're looking at that across the system at the moment. So why are we looking at dipsticks? Well, actually, dipsticks aren't as helpful as I think people felt they have been. They sort of crept in over time. They never were really actually launched as the diagnosis of UTI formally in all conditions, but they've slipped in because it's an easy test to do. And actually, the negative predictive value of a urine that's not cloudy is actually 97%, hence that answer of 3% earlier. And actually, that's higher than the negative predictive value of dipsticks. But it's not as easy as that. Even if you are finding bacteria in the urine, that is not a diagnosis of actually they've got urinary tract infection. Because the problem is you can have bacteria in the urine which actually aren't causing invasion, aren't actually causing disease, and this is the term asymptomatic bacteria. And you may have seen on our reports recently, we've actually changed them to help prompt for this fact that actually asymptomatic bacteria is quite common, particularly in older populations. And so the presence of bacteria alone is not an indication to treat. Does that make sense? There's only very specific scenarios that we would actually look to actually treat that. But routinely, that's not something you'll be doing. And actually, asymptomatic bacteria increases with age, and it's associated with long-term catheters. So that case that was being illustrated, if they sent a sample 2 weeks earlier, they would have got exactly the same result. It's not actually 10 years, anything's changed. And we've had scenarios in hospital where once a week urines were being dipped on orthopaedic wards and patients were being treated for urinary tract infections because their dip was positive on the day they did the dips, not understanding that actually that was a normal finding. And in the past, I think the thinking has been, well, antibiotics, they're innocuous agents, but they're not. we know that actually they increase the selective pressure resistance in that individual, but potentially resistant organisms that then can spread to other individuals, but also other side effects like Clostridium difficile diarrhea, but even hematological side effects, right through to some people can get really nasty Stevens-Johnson with antibiotics. So they're not innocuous agents. So Dipstick itself, I'll not find this pointer work, sorry, doesn't help us decide whether actually the bacteria itself is actually causing disease. It can't tell you that. There's a little video I'm just going to link to now that actually some people who've worked with one of my colleagues may recognise the voice. This is actually a national video. So the link's there, and I'd recommend having a look at that, and perhaps recommend it to other people as well. It's actually my colleague, but it's actually the voiceover for that, who did a lot of the work in the local care homes, looking at prescribing around urinary tract infections, and a number of prescriptions. A lot, when she first was starting to look, were being done just over the phone without assessment, based on urine dipsticks. So we're trying to get away from the everyone loves a dipstick, and we are doing a big campaign in the hospital at the moment, and we're, as you know, we've rolled this out in the community as well, but we're trying to get to every aspect of healthcare, because we have heard comments coming back. It's all very well, I'm being told not to do a dipstick, but then somebody comes to see the patient and says, where's the dipstick result? So it needs to be across the system. The trouble is, it's quite an easy test to do, and I think the approach has been, oh, not going to do any harm by doing it. But once somebody's got that result, then they feel they've then got to act on it. Very difficult to ignore a positive result, and then that sort of helps to reinforce the, oh, I've treated the urinary tract infection, even though you may be missing another diagnosis. And we've all seen examples of cases where a diagnosis of urinary tract has been just on the basis of dipstick, no symptoms, and they've been inappropriately treated and had alternative diagnosis, alternative infection, things like encephalitis, been missed because they've got a urinary tract infection that's not getting better with antibiotics. So asymptomatic bacteria, as the video explained, is where we find bacteria in the urine on 2 separate occasions. Then that would confirm it's actually in the bladder. But actually that's only appropriate to actually confirm it's there in the setting of somebody who's actually pregnant, where then we know that if we don't treat them, they've got a higher risk of preterm labour, and actually there is benefit to actually giving them antibiotics. But we wouldn't routinely say to confirm the asymptomatic bacteria. What actually we're trying to get away from is actually sending urines routinely. Giving antibiotics does not reduce their chance of urinary tract infections outside the setting of pregnancy, and even in pregnancy, there's now some data coming out that actually the evidence isn't as strong as it was believed to be, and that's being really looked at the moment, so that even that guidance may change. I think as people recognising actually the actual consequences of overuse of antibiotics, we've got to balance it. What it does do is increase resistance and side effects, and we know the elderly are at increased risk of side effects and interactions with all their other medication, so we can actually do more harm than actually good. So it's better that we actually don't test for it in the first place, because once we've got that result, then a whole chain of things then gets put in place. Exceptions, I already said pregnancy, and the other exception is prior to urological procedures, where we're actually doing an invasive procedure, potentially into a site that then you may get bloodstream infection from the bacteria in the bladder. But that's very specific scenarios. Every other scenario, we shouldn't be routinely dipping. So when should we be dipping? Well, I've come to that, but just some of the data which actually was covered in the video, actually to show that actually asymptomatic bacteria is quite high, and it gets higher the older you get, and particularly if in your long-term care setting, then it's even higher. And if you've got a chronic indwelling catheter, then 100% of them are going to be positive. So it really isn't a helpful finding. It's a normal finding. So associated with that, you're going to get that positive nitrites and leukocytes. Not a helpful test. So what is the harm? And the video alluded to this. Actually, we know that if we get positive dips, we then result in use of antibiotics. Use of antibiotics, I'm afraid, is doing harm. And it's the higher amounts we use of antibiotics, we know that there's a higher selective pressure for resistance. There's very good data out there that actually showing the countries that have high use of antibiotics also have the problems with multi-resistant infections. And we've also got some data, which I'll show you in a bit, that actually by reducing some of our antibiotics, we can actually start to reduce that resistance rates. So it is important that we try and address this area. And it's not just the resistance, but there are other harms as well. Drug toxicity, allergy, Clostridium difficile, and you may say Clostridium difficile is just a bit of diarrhea. We had a patient who had a colectomy for C. diff infection 2 weeks ago. So it can be the worst extreme, a very severe infection. But the other thing we see is actually they get a label of urinary tract infection, and actually the cause for their deterioration is being missed. And it can be simple things like dehydration, simple things like pain, or other infections, medication issues that actually need addressing, and not antibiotics for just asymptomatic bacteria. So there's new National Public Health England urinary tract infection diagnosis guidelines, which was referred to in that video. And this was developed with multi-professional stakeholders and was launched just a year ago now. And on the back of that, within hospital, we've actually got a sort of quality improvement target to actually improve the diagnosis and management of urinary tract infections, which is actually means if we don't meet that, we're actually going to lose money. So there's quite an incentive to improve this. But behind that is actually because this is going to be better for patients. And it's trying to get this principle across the system. So this guidance actually was initially for primary care, and it's been rolled out into secondary care. And our local guidance reflects that national guidance. And I'm not expecting you to see all the detail, but the video actually showed for the over 65s, this is the under 65 algorithm. But just bits to point out. It's important that you assess the patient to make sure they haven't got signs of sepsis, high-risk sepsis that actually needs to be in hospital. But the other important thing is actually the use of dipsticks. In the under 65s, actually if they've got classic signs, you actually don't need to dip their urine. You get to go on and treat based on that. And the other bit it highlights is actually if there's somebody who's having repeated courses of antibiotics, they're at higher risk of resistance. You should be sending a urine in that patient because, unfortunately, the microbiology is getting less and less predictable. So if somebody's having treatment after treatment, actually have you now selected out a resistant infection. For those who don't have all those classic symptoms, that's when dipsticks can be helpful, both for the negative predictive value, but also suggesting it may actually be a urinary tract infection. But you still back that up with cultures. In the over 65s, you don't perform dipsticks at all. Okay, so they've gone out of the diagnostic algorithm. You're still assessing the patient for sepsis or for a complicated infection. But the other thing is actually, what's the other causes for them being unwell? If actually you haven't got the classic symptoms of urinary tract infection, have they actually got other causes for the deterioration? But it's not just that, the diagnostic algorithm that we've had to change, we've also had to change the treatment of urinary tract infection. So 10 years ago, if you said to me, what's your first line treatment for urinary tract infection, what was it? Trimethoprim. Yeah. Okay. So why are we not using trimethoprim routinely anymore? So unfortunately, we were seeing an increase in resistance rates, and associated with that, we were seeing failures of treatment of people being admitted into hospital with pyelonephritis and with bloodstream infection. So it wasn't just the bugs were looking resistant, but actually didn't mean anything in the patient. we actually were seeing a difference in outcomes and response on the back of that.
Can I
Yeah.
just ask? Maybe there was a lapse in concentration, I don't know. I haven't found an indication for dipping the urine at all until now.
So if we just go back,
Yeah.
in the under 65s,
Yes.
it's this group here. Wait a minute. Let me do it. So that last circle there, those who haven't got all the classic symptoms,
Okay.
that is it or isn't it,
When
then
you're
that
not
can be
sure.
helpful when you're not sure, but not they've got the classic symptoms.
Right, okay. That is much easier because every time you don't want to run to the sluice.
Yeah.
If people have classic symptoms,
Yeah.
but they sort of turn up, so 40-year-old lady, classic symptoms, turns up, here's my urine, and it's sort of, okay, well, and then, but then it comes back and it doesn't have anything in. What's the positive predictive value of this? If it's an empty dip, can it still be urine infection?
Then it does think about the other causes, so things like vaginitis, etc. as well. So there is that wider, the symptoms, dysuria, etc. can be due to other causes. So treatments we've had to change because increased resistance. We've actually got some additional agents that we didn't have before, and we were concerned if we just changed from trimethoprim to one agent and we hammered that, we'd be in the same situation we were with trimethoprim, we'd lose that agent. So we're now able to have a breadth of agents that we can use to try and stop that selective pressure. So it isn't the same, because in the past people were having trimethoprim, they're coming back, they're having trimethoprim, coming back, they're having trimethoprim, because there wasn't much other choice. But the bit that's muddied the water is there's been the recent quinolone alert about, unfortunately, all the sort of connective tissue issues that we're seeing with quinolones, which has meant we've had to review our use of quinolones both in primary and secondary care, which has meant they've dropped down the treatment hierarchy because of that. This is just some of the local data looking at resistance, and the colours are different. Sorry, this pointer not working, it's a bit hard. The different colour bars are different age groups. So the blue on the left is under 16 and then orange is over 80s. And then we've got 2 years, 2017, 2018, and different antibiotics. So the common urinary tract antibiotics, the cefalexin, top left, fosfomycin, top right, ciprofloxacin, nitrofurantoin, comoxiclav, which used to be a favourite one for urinary tract infection, and maybe chest, and maybe this, maybe that, and pivmecillinam. And you can see of all of those, unfortunately, comoxiclav, we've seen quite a lot of resistance, which has meant that actually it isn't a good empirical treatment for urinary tract infection. So if you look at our guidelines, they're not featuring there as an empirical treatment because of that, as well as it's more likely to give you gut rot, C. diff, etc. So what are the agents we are using for urinary tract infection now, out of those ones routinely? Nitrofurantoin. If we look at nitrofurantoin there, you can see we're seeing very little resistance, and this has been used for years. And the reason behind that is actually nitrofurantoin doesn't get excreted into your bowel, into your faeces, so you're not selecting out resistant organisms in your faeces to then cause the ascending infection into your urine. So the only problem with nitrofurantoin, though, is it gets into the urine, but it doesn't get into the kidneys very well, and certainly not into the bloodstream. It's all excreted in your urine. So it's great for simple urinary tract infections, both because of low resistance rates, despite years and years of use, and also because it actually gets into the urine itself, but it's not good for the systemic infections. The other agents on there, ciprofloxacin and cefalexin, similar sort of resistance rates, overall about 10%. So that's why you've seen that our guidance has swapped. The cefalexin's gone above ciprofloxacin. They're similar in their coverage. The other thing you can see there is actually resistance rates tend to be higher in the elderly patients, hence the send in the urine. And this is the trimethoprim data, which is probably a bit easier to see because I've just got this. And again, actually, trimethoprim rates go up over age, except the under 16s. Why do you think we see more trimethoprim resistance in the under 16s? trimethoprim is still used quite a lot in paediatrics because of the issue of getting nitrofurantoin in the formulation for the little ones. So unfortunately, we haven't seen the drop in resistance that we've actually seen in the other age groups. So this is one we're having to watch very closely, and we actually have got some safety net in the guidance. But nitrofurantoin is the difficulty of getting the preparations, and the alternatives also are very difficult. You can't get those doses in the very young age groups. So what we've seen in our data? Well, this is some data looking at actually use of antibiotics at the bottom here, and this is our data is in the white circles. The England data is in black, and you can see our trimethoprim use has actually dropped much quicker than the rest of England. So when the national guidance changed, Nottingham changed its guidance. Everywhere else took ages to catch up, and we were actually being used as an example of actually there's a system-wide approach to actually changing as nationally we needed to, and a lot of that's on the back of actually having an area prescribing committee that actually disseminates things to multiple areas, whereas everywhere else is working in little silos. And along with that, we've also seen that actually our resistance to trimethoprim has dropped. So as we've used less trimethoprim, we've actually seen trimethoprim resistance drop, and we're hoping that over time we may actually get to a point where we can say trimethoprim is a suitable empiric treatment again. We're not there yet because the resistance rate's still about 25%. So a quarter of the time you're going to get it wrong. But it's better than where we were. We were running at 35% before, and in some groups over 40%. But also the other reassuring thing is, okay, we changed our treatment, but actually have we affected outcomes? We were seeing high rates of E. coli bloodstream infections, and actually in Nottingham we're seeing quite a lot. But we also send more blood cultures than other places. So if you don't look, you don't find. And we were in white there. We actually weren't looking very good against the rest of England. We were higher than the rest of England for the number of bloodstream infections, and it wasn't all explained by the number of samples we take. So that was quite worrying data. Changing our guidelines, we've actually seen that drop down. England's carried on going up, so at some point we're going to cross over, unless they do what we've done as well. So the treatments I really sort of alluded to, for pyelonephritis, we now have cefalexin as our first-line treatment, and this is instead of ciprofloxacin because of the MHRA alert, I'm afraid, and hopefully you've seen that. If you have got a urine and you know they've got a sensitive organism, trimethoprim is still a good treatment, but you need to know it's sensitive. You can't use it empirically, but you certainly can use it for targeted, actually result-based treatment. And ciprofloxacin, there you have to consider the safety issues. So it's not an easy an agent as it used to be, unfortunately. For cystitis, we use nitrofurantoin, but we've got other agents there as well, fosfomycin and pivmecillinam, that get into the urine. As you showed you earlier, the resistance rates are probably about 8%. So they're good empirical treatments, but we need to monitor that over time. Pivmecillinam has been used in Scandinavian countries since the 1970s, and they've not seen a rise in resistance. We can't assume we're going to be in the same situation, but that's promising data. But as I always say, prevention is better than cure. We need to be trying to prevent urinary tract infections in the first place. And certainly hydration is an important area. There's some good data in women who've had recurrent urinary tract infections, showing just by increasing their fluid intake, in the study it was by increasing it by 1 litre a day, they actually reduced the number of episodes of infections that they were needing to actually have antibiotics. And for some of them, they managed to break that cycle, probably because giving antibiotics affects your flora, and you're probably selecting out the more difficult pathogenic organisms. And so we've developed these local little How Healthy Is Your Wee posters that hopefully you've seen out and about. And we've also got guidelines for a recurrent urinary tract infection, actually what are the red flags actually when somebody needs to be referred on because they may actually have a structural issue or a stone, bladder cancer, etc. That's actually the underlying cause. As well as within this guidance, it's also got advice for patients as well of actually how they can prevent and also self-treat as well. And the guidance actually links now to the target guidance that's got this patient leaflet. So it's very comprehensive guidance there. That's just been updated with input from our local urologist. And I would, if you've not seen it, it'd be worth having a look at those resources. So there's a national drive to actually adopt this. So hopefully you're going to be hearing this from other places as well. We want really to embed this. So we actually get rid of the routine use of dipsticks. Actually, on some of our wards at Queen's, we've actually removed them. So they can't be routinely being used. We hid them for a while, they've now been removed. And our aim is actually keep antibiotics working. We want to be able to treat the patients who actually need antibiotics, so the patients with sepsis, the patients with pyelonephritis. We need to preserve these antibiotics for the future. Okay, thank you very much.
Thank you.